Welcome to the Waikato Palliative Care Echo. We're going to make a start and hopefully we'll have some more people join us as we go. So my name is Wayne Naylor, I'm the Director of Nursing here at Hospice Waikato and I'm facilitating the meeting today. Just going to start by getting people to introduce themselves. There's not too many people to introduce, so it shouldn't take too long. So we might start with Maddie. That's all right.
Good morning, everybody. Yeah, it's just before Easter. I'm Madeleine, I'm from Hospice, and I'm also a rural CNS and a lymphedema therapist.
Morning, my name's Wendy. I'm one of the community nurses and also a therapist.
Great, welcome. And we'll go to Robin.
Oh, hi. Can you hear and see me?
We can hear you, but we can't see you. So you might need to turn on your camera or turn your video on.
Oh, that one. Okay.
Oh,
so
yes.
I'm an ancient physician now living in Gisborne, and I do some work with Hospice Tairāwhiti. And rather than get out of bed too early, I joined in from home.
Oh, good. It's really nice to have you join us, Robin. And we'll just go around our table now. Start, Adam.
Hello, I'm Adam. I'm the IT support.
I'm Brian Enser. I'm the medical director here.
I'm Linda Rademacher. I'm a member of the board at Hospice Waikato.
Good morning, I'm Andrea, the education coordinator.
I've already introduced myself.
Good morning, my name's Debbie Barham. I'm palliative medicine specialist here at Waikato.
Kia ora, I'm Jackie Swain and I'm a nurse educator.
Good morning, my name is Karen O'Reilly and I'm a social worker with Family Services team here at Hospice Waikato.
Good morning, my name is Gail. I'm the spiritual care coordinator here at Hospice Waikato.
Good. I'm just going to go through how the meeting runs and just some of the etiquette for the meeting. So Adam, can you just bring up that shared slide? So we're just going to share our screen. Hopefully. There we go. So just a few things to remember as we're going through the meeting. One of the key things is the case study we're going to present is presented as an anonymous case. So we will do our best to make sure that there's no identifiable health information shared. If you do happen to know the person or the patient's being discussed, then just maintain the confidentiality of the patient as well. We are recording today's session and we use it for educational purposes. So when you're speaking, if you could identify yourself and look at your camera is good. We will also be managing people's mute buttons, so there's no background noise going on when people are talking. So if you do want to ask a question or say something, you just give us a little wave and we'll unmute you. Yeah, just remember, we're a fairly small group today, but just to identify yourself when you speak so that people know who is talking. Just for doctors who are here in particular, our palliative care echo is endorsed by college of GPs for CME credits. And we also provide a certificate at the end, so any other health professionals can record their continuing professional development hours as well. So the agenda for today, we've done introductions. We're going to have a short teaching session from Maddie on lymphedema and palliative care, and then a case presentation for discussion that Maddie and Wendy are going to present. So just for people who haven't done this before, the process for the case discussion is we get the person to present the case. You should have been sent the case study as a document, but we also will put it up on the screen. Once Maddie and Wendy have finished presenting the case, we'll just ask if anyone has any questions or clarifications about the case, and we'll do a sort of a round the houses, give everyone an opportunity to ask questions, and then we'll move to recommendations for managing the case. And I'll try and summarise the recommendations at the end. So I'll hand over to Maddie now and ask her to do her presentation on lymphedema. Thanks, Maddie.
All right. Next slide. Okay, so good morning, everybody. And just what I'm talking about today is the lymphedema and our management of lymphedema and advanced cancer is just a snapshot. And there are so much that we can know about it. And so it's really just to get an idea what we are doing. We are both trained Australasian Lymphology Association affiliated schools. So I trained through the Bodder and Casey Smith School, and Wendy trained through the Close School. Today we are going to define what is lymphedema. We're going to talk about differential diagnosis and the treatment options. The case study, just a warning about that, there is some graphic images that is going to be quite, can be quite upsetting so early in the morning. But I'll let Wendy just start about lymphedema and then I will carry on again. Thank you.
Thank you. Well, I'd like to start our presentation by telling you just a little story. And this is in order to raise the profile of the lymphatic system, which is sometimes rather poor relation compared to the cardiovascular system. So the story begins in 1896 with Ernest Starling, who was a physiologist, and he spoke about the theory of equilibrium. And basically at the capillary membrane, you get the blood capillary pressure forces fluid out at the arterial end of the exchange, whereas the plasma colloidal oncotic pressure reabsorbs the fluid at the venous end. And therefore you have what he proposed was a state of near equilibrium, where most of the fluid which is filtrated out at the beginning is reabsorbed at the end. Only 10% of the fluid remains in the interstitium. And so therefore the lymphatic system is really only dealing with 10% of this filtrate. Now this theory lasted about 100 years, and it's only in 2010 that Levitt et al. Suggested that what the system actually is a system of dwindling filtration. There's actually no reabsorption, and so the entire filtrate needs to be reabsorbed by the lymphatic system. So the lymphatic system plays a much bigger part than we'd originally thought in terms of fluid management. So, okay, what is the lymphatic system? Well, a quick synopsis. It's a one-way system, and by that I mean it takes fluid from the tissues and back into the heart. It's composed of a network of vessels and nodes located throughout the body. The superficial lymphatic capillaries are just underneath the skin, which is an important point for us to note when we're doing our massage. There's a system of network vessels and nodes which take the blood back into the heart. So what is lymphedema? Well, thus saith the British Lymphology Association, lymphedema is a chronic progressive condition. It leads to the excessive accumulation of protein-rich lymph fluid in the tissues, and those are important. And as a result, it results from lymphatic failure, which can be due to either congenital abnormality or due to damage to an existing lymphatic system. It's been divided into primary lymphedema and secondary lymphedema. Next slide, please. So primary lymphedema. This is a mechanical failure, and it's usually caused by imperfect or abnormal development of lymphatic vessels. It's often hereditary. It's a genetic disorder. There's usually a family history, for example, Milroy's disease, but it can be sporadic in that it occurs just spontaneously. If it develops before the age of 35, it's known as lymphedema precox. If it's after the age of 35, it's known as lymphedema tardis. Next slide, please. So secondary lymphedema, this is our area of work really. We've listed all the causations of lymphedema. And we put filariasis as the beginning one, as the main one, because that is endemic in 73 countries. There's 123 million people worldwide who have this disease, and as a result, 40 million people actually have lymphedema. It's a huge, massive problem, as you can see. But in the Western world, malignancy is the major cause of the lymphedema that we see. It also be created by surgical complications, the result of radiation, trauma, or infection. Next slide, please. So, differential diagnosis. Lymphedema, edema, you've got a patient with swollen legs. What is it? Does it matter? Can we tell the difference between the two? Is there any significance? Well, as we say, the situation before us is often multifocal and is often quite complex for a number of reasons why people could present with edema or lymphedema. Next slide, please. So with edema, we also call this dynamic insufficiency. And in this situation, you've basically got a functionally intact lymphatic system, but the volume of fluid known as the lymphatic load, which the system has to drain, is greater than its capacity. And so what happens is you get low protein edema in the interstitium, because blood proteins drain out and leak out into the interstitium, and because you get this extra fluid there which is unable to be drained, it dilutes it out, so you get a low protein fluid remaining in the interstitium. Examples of this would be cardiac conditions, renal conditions, chronic venous insufficiency, dependent limbs, maybe due to immobility or neurological deficit, and also hyperalbuminemia. It's a symptom of the disease, and it's significant for us particularly because our manual lymphatic drainage is ineffective. Basically because manual lymphatic drainage is designed to increase the function and the transport of the lymphatic system, but obviously it's already working at maximum capacity, so it therefore can't respond by uptaking even more fluid. So that's edema, dynamic insufficiency. Next slide, please. But in the case of lymphedema, this is where you've got a mechanical, or it's known as mechanical insufficiency. And in this case, you've got a normal lymphatic load, that's perfectly normal, but because of organic or functional causes, perhaps due to metastases or primary tumour, the transport capacity of the lymphatic system is reduced, it's blocked, and therefore the normal lymphatic load cannot be drained. You get protein-rich fluid, therefore, just remaining in the interstitium, and this is lymphedema. It's a sign of a disease, and our manual lymphatic drainage is appropriate because we can develop new pathways, open up watershed, cross watersheds, and develop new pathways for the fluid to drain out. So that's, yeah, important for us. Next slide, please.
Right, so we are going to, how do we diagnose lymphedema then? Mostly we focus on the clinical signs of lymphedema, and that mostly occur in the skin and subcutaneous with protein-rich materials and lipids that accumulate in addition of water. We're also looking sometimes that we use the stemmer sign, and that is an inability to pinch a fold of skin and a dorsum or the base of a second toe, as well as a middle finger. So those are the most important signs, as well as skin changes. In chronic lymphedema, the skin becomes thicker and also has more hyperkeratosis, can develop papillomatosis or brawny induration. Next slide, please. Lymphedema can also be diagnosed on a history of clinical findings using imaging techniques such as a lymphoscintigram. With a lymphoscintigram, there's a type of isotope that is injected in the middle toe, and that then gets absorbed by the lymphatic system. As you can see on the right, you can see where it was injected and up to the groin where it's evident now. But on the left, you can see there's still a lot of, what do you call it?
The dye remaining?
Yeah, the dye remaining in the tissue. So the drainage on the left side is less evident than on the right side. Next slide, please. So with an lymphedema management and palliative care, it is really important to understand the uniqueness of each patient. Each patient that we get to know is different, and we have to look at that holistically. It's also about teamwork, what is need to be done, and we decide as a team what is most important for this patient, and clear communication to the patient and the family, what can be expected and what goals can be achieved. I think honesty is really important. It helps them to manage it much better. Sometimes we need to be really creative in what we are doing. Like sometimes we will just do bandaging half a leg, where normally it would be a full leg if it is normal lymphedema and not an advanced cancer. Also to talk about fears and expectations to the patients. With a patient going through treatment and palliative care, they sometimes really, any new signs, they relate to cancer. So to talk about it and to let them understand what is happening, and if they understand what is happening, it's much easier to deal with it at times. Next slide, please. So the principles is the patient's priorities and goals, what they would like to achieve and what is achievable. To look what can be reversed, like anemia, draining of ascites, management of cellulitis, management of skin, and to look what is going to benefit this patient and what is going to be really become a burden. For some patients to have a daily bandaging episode may not be the solution, because it may they may not be able to mobilize, and it put them at risk of falls. And then also, what is the patient's general condition and prognosis? And then psychosocial issues. How does a family support this patient, and how can we help them and teach them to support and help with the drainage? Next slide, please. So we need continually to ask, is it primarily life prolongation, or is it comfort and quality of life? Next slide, please. So we have got different treatment modalities. The skincare is one of the most important treatment options, is because broken, cracked and dry skin is an entry point for infections, and we encourage patients to use creams or emollients or moisturizers to keep the skin moisturized and in a good condition, to inspect the skin on a regular basis for any areas that may develop an infection, and also even little things like using tea tree oil and water to soak their feet, because it is an antifungal prevention. It's all little things that can help in the main picture. Remedial exercise is also important, and you would think, our patients can't be physically active as they need to be. However, they can do quite a bit, but because with the lymphatics, it is just the minimal exercises that can encourage the lymphatics to pick up the lymph fluid and drain, like for instance, breathing exercises, or even moving their arms and open their hands and close their hands to try and encourage the lymphatic fluid, or otherwise feet while they're in bed, do some exercises with their feet. We use compression bandages and garments. With the compression, we many times only use what the patient can manage, and that can be perhaps just a day or half a day, and then, or otherwise we sometimes only bandage up to the knee. We have started to use adjustable garments, which is really helpful because they can put the garment on, take it off as it needs, and it's not as difficult as to put on as a compression garment that is stiff and hard. If we do use compression, we use normally the lower grade so that it's easier for them to manage. Something else that we use is kinesio taping, which is developed by a Japanese chiropractor, and is a specialized tape. It's 100% cotton and acrylic heat-sensitive glue. So the tape just lies on top of the skin. It models the skin characteristics and unique properties, and it allows it to lift and open superficial lymphatic pathways and provide directional pull in the desired direction of drainage. So many times with patients with scrotal oedema, we use the tape to try and drain it away from the scrotal areas. Lymphocentesis. Now I know Nurse Maud, lymphocentesis is subcut drainage of lymphatic fluid. Well, we haven't really used that here at Hospice Waikato. However, Nurse Maud and Dr. Landis has used it down south, and there has been quite a lot of studies around how to use it, but there's also criteria when it should be used, who should be the patients, and it's really, I would say, the last resort. Drugs, no benefit of furosemide, or it just might, because what happens there is that they drain the fluid, but the proteins are still left behind, which cause the skin to become hardened and more difficult to manage. However, antibiotics and antifungals are required for infection and maintain skin integrity. Next slide, please. Just to go back to that previous slide, sorry, can we just go back to the previous? I think we must never forget the importance of touch when we have patients and look after patients. You know, when we show patients how to manage or do lymphatic massage, it is sometimes open a door for them to be close to their family and to do something for them really special at that stage of their lives. Next slide, please. So the treatment options that we have in the lymphatic area is decongestion and maintenance, but it is less evident when we manage patients with advanced cancer. So I'll explain that with the next slide, please. Oops. Okay, so with the standard management of decongestion, we normally have a goal. We reduce the swelling, we change to garments and lifelong maintenance. And there's normally 4 elements, which are skincare, exercise, bandaging, compression garments. So it's very defined in 2 stages, the decongestion and the maintenance phase. We're in palliative. Next one, please. The goal is to comfort, support, relief of symptoms, and maintain function. So we look at it differently, and sometimes the elements of the management is less defined, and it's not so clear, decongestive or maintenance. There's also the contraindicators are relative, so we sometimes will discuss things like cellulitis, or if a patient has been treated for DVT, we sometimes will still continue with MLD, but proximal to the DVT. Now, however, that decision is never made just by the lymphedema therapist. It is in combination with the rest of the medical team before we actually would do that, and the patient would have had anticoagulants and treatment already. Next slide, please. So, and lymphedema, management, there are contraindications like uncontrolled cardiac and renal failure, recurrence of disease. Sometimes we get referrals where GP would say patient has had breast cancer and now has developed lymphedema. As we would not do lymphedema management unless that patient has been seen by oncology and unless that has been defined as if it's not a recurrent of disease, because otherwise they will need to be treated and examined first. Venous complications like a DVT, which is usually unilateral, and it normally presents with pain and tenderness and swelling. So it's normally, with lymphedema, develop over time, normally weeks and months, whereas a DVT is normally quite quick, within 72 hours. So we need to exclude DVT, especially in our patients, because DVT is quite high and developing in patients with advanced cancer. And cellulitis. Now, cellulitis will develop quite easily with patients with the lymphedema because of the lymphatic fluid doesn't drain as easily as it should. And there are some obstructions. So, however, the ALA, or the Australasian Lymphology Association, has got guidelines that you can download if you need to. In that, they also say that sometimes the inflammatory markers, for example, white blood counts, CRP and ESR, is not raised, especially with patients with advanced lymphedema. And antibiotics is not always dependent on a blood test, but sometimes a clinical presentation, meaning the patient's unwell or there's redness and increased temperature. Okay, next slide, please. So our practical tips for today is, most importantly, is a skincare. We are, both myself and Wendy are here for advice. If you want to phone us, there is quite a lot of, at the end of the slides, you would see there's a lot of information that you can get online. So that's important. Elevation of the limb or the arm, gentle massage. Now the massage with lymphedema management is really gentle. It's literally touching the skin and just gently move it. So as you touch your skin, you can feel that your hand is on the skin and you just gently move it. Then you can feel it. You only move the top part of the skin, and we normally move from a distal to the proximal to avoid main areas of obstruction. We normally will teach the patients simple lymphatic drainage techniques and will guide them through it, how to do it and which direction. We will also give them a body map to show them what is important and which direction they should move the lymphatic fluid. Sometimes things like use a shower ball or a small paint roller, always use it to distal to proximal and use that gentle movement, because anything that, you know, just touching the top part of the skin and encourage the lymphatic fluid to move can help. Even if you put on cream or emollients to try and do it in one direction, not just to put on cream and, as we always do it, you know, just rub it on in all directions. Deep breathing exercise and monitor for any sign of infection, because the sooner you treat that, the better. Next slide, please. So lymphedema is a lifelong condition. It can develop years after treatment. Monitor for skin changes or infection. It's important to protect against sun and insect bites because of the lymphatic system is not working as best as it can. To maintain a healthy weight and diet, to do some exercises and educate patients about what they should do and what they should look after. diuretics is not effective. I think we must always keep in mind the economic impact of lymphedema management. It is really costly, and before you decide to order garments, it's really, really important that they go through all these phases of decongestion and managing it to get the lymphedema management as best as possible before you actually get a garment, because otherwise they use the garment is too tight, it needs to be refitted, and it's just not worth it. MLD therapy is a gentle rhythmic movement, and to please just be aware that of lymphedema and send us referrals or ask us or phone us and ask for advice. Next slide, please. So although it can be challenging to manage, it is possible to modify existing modalities, and there are more and more evidence in managing lymphedema and advanced cancer. Next slide, please. There are lots of educational opportunities. A massage therapist is not a lymphedema therapist. A massage therapist needs to have had education in lymphedema management through, and it's best to have it through an association that is affiliated through the Australian Lymphology Association. So please, let's be aware of that, because there is a difference. Next slide, please. So, and that's just some websites that can be useful in management. Thank you.
Thanks very much, Maddie and Wendy. That's very interesting, very informative. I just wonder quickly if anyone has any questions for Maddie or Wendy. Robin, did you have any questions for them? Anyone here have any questions? Yeah, Gail.
Maddie, the thing that stands on top for me with when I see these patients is the change in body image and how they're coping with that. Can you say something about your experience there?
Yeah, you're quite right, Gail. That can be really huge for people and does make a big impact for them. And I think often people, if you are able to do just a little bit with them, or even just, you know, pay attention to the swelling, they actually feel that something done about it. It does help to renew that sort of sense of hope. And if you are able to get the limbs down into reduce the swelling in like garments or support types, it can be, as you see in our case study later, it can be a really big thing for people. It can just revolutionise how they see themselves and how they see the progression of the disease, because often, you know, they've gone with this disease for a long time, been struggling with it, have the swelling, and it just seems like, you know, things are really bad. And if you actually manage to make some kind of impact for them, it's a big thing.
Yeah, and I think one of the most important things I've learned is that you may not always see the visual changes, but for that patient, you have made a change. And I think we need to keep that in mind, because they don't develop lymphedema over a couple of days. They develop it over weeks and months. And the treatment is not going to happen within a day. It's also going to be weeks and months, you know, especially if you go through the massage or MLD. It takes time to work through it and to try and improve the lymphedema.
Thank you. You want to ask?
I'm not sure what's coming out of the case study.
Lymphedema case study.
Doctors often get asked to do steroids as their sort of drug benefit thing. That may come out as a discussion at some stage. The taping, I've never really understood the taping, and how accessible is taping around the countryside, and do you need particular training as you do for the massage? Question in brackets, do we have to call it massage? Because I think that's really confusing, because massage means, you know, getting in there, and everybody that talks about lymphedema massage says it's not massage, it's It is, but it's not. It's touch. Yeah, so taping, is that, like, can you get that outside a lymphedema specialist?
You can get typing. The physiotherapist many times use typing as well, but with the typing that we use in lymphedema management, we are both trained how to apply the tape. So we have got access to the tape, and there are treatment, what do you call it, training schools for typing, lymphedema typing. So it is different, and it's also applied differently than physiotherapy. And I agree with you that we try and use the word more lymphatic drainage than massage, because massage becomes a word that I think it's a physical massage, and it's definitely not that. Yeah.
When you apply the lymphedema taping, the idea is to sort of put the tape in the swollen area and progress it across the skin and across the watersheds between the different areas, and end up with the end of the tape being in a sort of normal area of lymphatic drainage. And it's like a micro massage of the skin, and as people move, they have to really be reasonably mobile, because it does depend on them being able to physically move around. But as they move their limb, that stretches and eases the tape, and that in effect, because it does glue quite well to the skin, as it actually lifts the skin in little patches as they move and mobilise, and that provides this gentle sort of movement, which will hopefully drain the fluid from the area that's swollen into an area where the lymphatic drainage is normal, and it can be removed by that. You can see it working quite well in like areas. If someone has a hematoma, I mean, you can actually see, you put the tape on, the kinesiology tape, and you can see how it's, the area clears along the lines of the taping. So it definitely works, and it can be a more gentle form than actually trying to bandage people, because the bandages can be quite difficult to tolerate. And so if you get people who, quite frail and quite weak, but they do have a swollen limb, then sometimes a little bit of gentle taping can be helpful.
Yeah.
Cool, thank you. So I think we better move on to the case study now. So Maddie and Wendy are going to present a case. So as I said, the process of this is spend about 5 minutes going through the case, and then there'll be an opportunity for people to ask questions, and then we'll move on to a recommendation. So we'll just bring the case study up on the screen, and I'll hand back to Maddie and Wendy to present the case, and then I'll open it up for questions and clarifications. So thanks, guys.
Our lady is called Judy. It's not her real name, but that's the name that we've given her today. She's 55 years old. She was diagnosed in July 2017 with stage 4 SCC with the right groin and hemipelvis nodal involvement. She also had lung mets. Now this lady has had 2 grown-up children. She lives at home with her husband, and she was part-time employed before the diagnosis. So she went through chemotherapy, and she had radiotherapy as well to decrease the size. In the beginning of April, she developed localized fungating mass, which was erythemus and malodorous, and she had surgery. So she had quite a bit of surgery to that area, and then she also had, they couldn't continue with the chemotherapy because she developed quite a bit of, skin irritation. Yeah. And so they stopped the radiotherapy and also the chemotherapy at that stage. And then she started with some more, in early May, she started with pembrolizumab. She also has a past medical history of stage 1 granular cell tumor, and she had that removed in November 2016. So her main problems with pain. Initially, paracetamol and codeine with Sevrodol was given, and then progressed to Emerslon, and she was admitted to a hospice with a pain crisis. She was rotated to methadone, and that's where we met this lady, Judy, and we used massage or MLD and mindfulness to help her to elevate the pain, which is also one of the big benefits from manual lymphatic drainage, is that if you can actually reduce pain in patients with advanced cancer. So the lymphedema management was to discuss the goals of care and to enhance the healing of her wounds on the right upper thigh and reduce fibrosis. If you look at I think I will go down to the pictures once we've done just all of this, otherwise we're going to go up and down. So initially when we saw Judy in the hospitals or hospice, it was quite really difficult to think, where are we going to go? And I think this case study illustrates that it's not easy. It doesn't happen over weeks, or it takes months. And it also takes a lot of other people to be involved, like the team the nurses that did the dressings. They've done an amazing job doing that, and as well as the other part of the team with the pain management. So the plan we had was a manual lymphatic drainage, special attention to the fibrotic areas, where we use different types of lymphatic drainage techniques to reduce the fibrosis, as well as around the wound areas. I think many times people don't realize that they can be quite involved with wound management, because you can reduce the swelling and enhance healing, as well as remedial exercises. And then skin care and wound management was impeccable, and the nurses that has done the dressings was really great. So we progressed into compression, where we initially used the adjustable garments that she could manage herself while she was at home. Once again, we only used the lower leg, and then she managed the upper leg herself by doing the massage techniques that we have taught her. So, and then we progressed into a garment eventually. So just to look quickly at the psychological and psychosocial, this Judy was really quite concerned about what's happening with her. She's a youngish woman. There's still a lot of things that she wanted to do. Even though so many changes has happened to her leg, there was nothing really that makes her unwell, except the pain and the discomfort and not be able to mobilize. So the family services team was involved with her as well. She did not attend church, but she does have some spiritual beliefs, and she tries to remain positive. She still attends the creative therapy group. I think when we look at our ethical issues, there's major things for us here about the resuscitations. She's got a private surgeon, and her mum is actually funding the treatment for her. So how long that's going to be able to happen, we don't know. And how do we cross those bridges when we get there? It's going to be quite difficult, because even though she has improved and the lung lesion has diminished and the leg is really looking good at the moment, there is still the possibility that things is going to change. And she is aware of that, but I think that's going to be real difficult discussions to have. So it is a multidisciplinary team effort. I just want to, if we can go down to the images, please. So when she initially presented to her oncologist, she was treated and she went home and after radiotherapy, and she developed this lesion on the 5th of March. That lesion, if you go to the next one, with I would say 10 days, it has progressed to that amount, and so that's when she went to see the oncologist at Waikato. Oh, I shouldn't say that, sorry. On the 22nd of March, it's even further progressing. So if we go up to the next one, it's the same lesion. And then on the 25th of April, it's even more evident, and that's when they excised it, and they have done then a skin flap, yeah. And then on the 4th of May, that's where we met her actually, or just soon after that, she was admitted to IPU. And at the moment, after all of that, if you look at the next one, that is how she is today. And that's a year after the treatment. Now, I do want to acknowledge that it's not just our work, it's the work of the nurses that were involved with wound care, as well as the Keytruda that she has been on. She's really responded very well to the Keytruda, and she and herself and her husband has been really active in trying to manage this at home and to keep on top of the MLD and maintain a skin integrity. Did you want to know? Right, any questions?
Let's stop share.
Yeah, we'll just come back so everyone can see each other. So just wondering if anyone has any questions. Robin, did you have any questions or clarifications about the case you want to ask? Okay. Anyone here? Any questions, clarifications? Just questions?
Yeah, just a question. Do you know whether they had considered doing surgery sooner? You know, when the tumour would have been smaller?
I think they didn't expect that tumour is going to grow so rapidly in such a short period of time, because it's within a month.
Yeah, she wouldn't have got any.
I think, and also we hardly ever do a surgery on a fungating wound. It's not something that's done. Wayne can answer that as well. It's not something that happens easily.
Thank you.
The tumour's growth was stimulated by the radiotherapy. It sort of had an adverse and completely dramatic effect in actually stimulating the cells to produce. This was what the patient told us, and it would seem to tie in really, because it followed quite soon after she'd had the radiotherapy, and it suddenly just shot away.
It's resistant.
So whether that's the case or not, I'm not sure, but interesting.
Anyone else have any particular questions or clarifications?
I was just going to say that the body image question earlier on is really, this resonates very much with me, because that must have been a very big part of the improvement for that patient.
Huge, and she was very it was absolutely devastating and terrifying, I think, for her to watch that grow. It must have been just enormous. She was very, very fearful, wasn't she? And at the time, and just wondered where to from here. She was absolutely desperate, and I think there was, obviously there's a lot of odour associated with it as well, and just the whole thing was it's been very traumatic. But a really good outcome, for which she's absolutely delighted.
So there's a couple of questions you had related to this case, Maddie, and one of them was around, did anyone have any other questions around lymphedema? I think we've covered that pretty well. And then the other question was, are there any other treatment options or modalities that maybe could have been used for this patient as well? So I just wonder if anyone has any, if we move on to any recommendations or suggestions for this patient, if anyone has anything they wanted to suggest, add or comment on?
Comment?
Yeah.
So Debbie here. Kind of a question, kind of a comment. I guess that this was an amazing dramatic improvement for this lady in a specialist unit. But going back to, I think, Brian's question earlier, you know, what about patients who are not close to us, the people who are out rurally or who can't travel? What access do they have to lymphedema therapists? You know, not all are registered, as you said. So there are people who've set up a clinic somewhere in their little hometown, and they, you know, how do people know where to go? And what the other question is, what funding is there for this? So you mentioned the expensive garments and things in particular, but you know, for the general public out there in the community, accessing treatment for lymphedema is expensive. Are there ways that we can support them with that?
What we normally encourage people to do is to initially make contact with us, and then we can advise them who may be the closest lymphedema therapist, because we have international and the national register that we are in contact with, and we can email the other lymphedema therapists and they can let us know which one is the closest in that region that could be involved. You can also use the ALA register. We both registered on the ALA, but there's also what they call a national NPL, I can't remember what it stands for, but there's a national register as well that you can look on New Zealand website to see whether a patient is registered, and that is also under those on that slide about the websites. There's some information there that you can look there for lymphedema therapist that is registered in lymphedema management in New Zealand. Yeah.
I think one of the things I had trouble with as a GP was accessing, you know, you would try and access funding through disability allowances and things, but without knowing who the registered therapist is in your area, that often got turned down. So I guess as a recommendation for people out in the community would be, as you say, to contact us so that we can give that advice, and then there's a specialist service involved, you're more likely to get funding through a disability allowance. So just thinking outside the box for access for people.
Yeah. The DHB does fund 2 garments a year for patients. Yeah.
And the tape.
Once they are seen and once they are seen referred, they can be seen by the orthotic people, and they can be measured for garment. But it's really important that they have some management before they actually go for the garment, because many people, like even we get, say the sleeves are too small now, it doesn't fit. It's not going to help me just to send us straight to the orthotics. You need to look at ways how you can reduce it somehow, or a little bit before you actually have a garment fitted.
I'll just make one comment just in relation to the surgery. So I think that you're right, that surgery for fungating wounds is infrequently used, but in the right cases it can have, and like this lady, dramatic impact, because the whole wound can be taken away, so you remove all the symptoms of odour, exudate, body image impact. But the problem is, from my reading of the literature, there's very little published about palliative surgery for fungating wounds. But there are some really good, quite dramatic case studies like this one, but probably only 3 or 4 maybe. So I'd really suggest that you guys get together with the other team and write this case up and publish it, because people need to see that you can do this and what the outcomes are. Yeah, I don't know why it's not done more frequently when tumours like that are easily removed, and there is a fairly easy way of repairing the tissues. There are risks with the radiotherapy if they've had that previously with healing and potentially the tumour regrowing, but but still you can often get a prolonged period of no symptoms and no wounds. The other thing I was going to say, I did have a question around the family involvement, and if you guys were able to get the family involved in helping with the treatment for this patient, and how you would do that. And I know you kind of mentioned that it's a good thing for family members to do and for touch, but how do you get people feeling comfortable doing that?
Well, it's just a question of sort of demonstrating initially what needs to happen, and I think once people feel confident and they've been shown and we give them sort of diagrams, we can, you know, start quite simply. It's not a complicated kind of thing. People do, you know, they often do want to be involved and do want to contribute, and I think, you know, the more that can happen, and the better that is, because that sort of shares the care between everyone, and it's no longer just the patient's responsibility to manage a disease, but, you know, to bring in the family and whānau can actually be really helpful. So, yeah, I think that's something that we try and encourage as far as possible.
Yeah.
Can I add to that, the strength, I think, in the IPU setting was the multidisciplinary approach to that. That sometimes that there's a fear of touching someone who's unwell, or the person, because of their body image concerns, doesn't want that area touched. They just don't want that to be the feature of their relationship with their loved one. And so often having the counselling team, the allied health team, to just unpick some of that, to be able to explain how it's helpful and demystify some of it, just remove some of that fear. I think that's something that as a specialist service we can offer, but how can we help people out there who can't easily access us, or who have limited access to things like counselling or spiritual support in the community? Just being aware of that, I think, so that we can support where we can, but that's an area that we need to strengthen out in the rural areas, I think.
Okay, if there's no more, sorry. We'll just unmute, yeah. Okay.
We have managed a patient down in Tamaranui once, and also seen the patient once initially, and then with the guidance of talking on the phone, because you have seen the patient and you knew what you were dealing with, we could continue to manage and support that patient at home. I think it's mainly just try and see the patient once or twice so that you can guide them. It's one of the most important things in the MLD. Yeah.
All right, so we're just about out of time. Just to briefly kind of summarise some of the things we're discussing around this case was, one, the importance of body image and the dramatic impact that this tumour had on this patient, but also the change as well with the surgery and with the lymphedema management. The issue around access outside of Hamilton, we probably do pretty well in the Waikato, because I don't know how many other hospices provide palliative lymphedema services. Not very many. I think probably 2 or 3, isn't there? And because these guys can be mobile as well and see patients out in the area, but I guess just being aware of how we can provide advice. And I was wondering, maybe you guys could think about this, of having some information on our health professionals page on our website around lymphedema and who to contact for advice, and maybe some of those websites. Just the options for palliative surgery for fungating wounds as well, and trying to make people a bit more aware of that for the right kind of patient. And then, as Debbie said, the MTT approach, working with the family and the patient, addressing fears and concerns and encouraging them with more involvement. That was kind of the main things from what I picked up. So thank you guys for an interesting case. Our next echo is on the 16th of May, same time, 7:30 to 8:30, and the topic for that one is actually, it's me presenting on something carrying on from today, I suppose, on how to manage wound malodor just the causes of it and some new and fairly simple approaches to managing that. So hopefully everyone can join us again, and we hope to have some more external participants next time as well. We'll be getting out there and encouraging other GPs and services to join us, and we look forward to seeing you then. So have a great day and a great Easter, and we'll see you in May.
Thank you.
Thank you.
Do it.